Epidemiology of Communicable Disease. Last lecture we started regarding the introduction, and today we will start with the epidemiology of viral infections. So the first thing to start with is measles. Measles is an acute, highly contagious viral disease and caused by virus, characterized by generalized maculopapular rash, fever, cough, runny nose, red erythematous rash, with what's called complex spot. An uncomplicated measles infection, the first symptoms are very similar to early symptoms of influenza. So started like symptoms of influenza, and difference between these two viral infections is by looking in the mouth. Then 2 days of influenza-like symptoms, people with measles develop complex spots on the side of the mouth, and these can be seen on day 2 through day 6 of the infection. The typical complex spot is 1 to 2 millimeter, blue to white spots, even with a reddened background on the inside of the mouth and across from the molars. The disease may be complicated with bronchopneumonia, encephalitis, hepatitis, and the lived attenuated measles virus vaccine has been utilized widely since 1965. The reservoir is human, and there is no known animal reservoir. And characteristic measles rash, classically described as generalized maculopapular erythematous rash that begins several days after the fever starts. It starts on the head before spreading to cover most of the body and often causing itching. The rash is said to stain, changing color from red to dark brown and before disappearing. Measles rash appear 2 or 4 days after initial symptoms. Contact with the fluid from infected person's nose and mouth, either directly or through aerosol transmission, and is highly contagious. 90% of people without immunity sharing living spaces with infected person and will catch measles. Asymptomatic incubation period occur 9 to 12 days from initial exposure. And infectivity lasts from 2 to 4 days prior until 2 to 5 days following the onset of rash, i.e. 4 to 9 days infectivity in total. And this is very important because patient without rash might be infectious to others. The pathogen is measles virus. It has been classed as paramyxovirus, and it is spherical in appearance, measuring about 100 to 150 nanometer in diameter. It has an outer envelope composed of M protein, H protein, F protein, and internal course RNA. The site where this virus exists, it can be detected from blood, nasal, pharyngeal secretions. Resistance measles virus is sensitive to heat or disinfectant, and it's also inactivated by ultraviolet easily. It is not strong. Regarding the epidemiology, which is the most important source of infection, the patient are the only source of infection. The route of transmission is airborne, and susceptibility of population, all age persons susceptible. 90% of contact people acquire the disease, so it is highly contagious, and the permanent immunity acquired after the disease. Regarding the epidemic features, They are in winter and spring, and age 6 months to 5 years old mainly. Mortality in developed countries is 1 in 1,000. In sub-Saharan Africa, it is reaching almost 10%. In case of complication, the rate may rise to 20 to 30%. On average, about 450 children die every day from measles in a very high epidemic countries. Even in countries where vaccination has been introduced, rates may remain high. And globally, measles fell 60% from estimated 873,000 deaths in 1990 to 345,000 in 2005. So there is a decline in the mortality of this viral disease. An estimate from 2008 indicate death fell further to 164,000 globally, with 77% of the remaining measles deaths in 2008 occur within the Southeast Asian region. In Iraq, measles cases is 1,121 all over the country. These are old numbers, not current at that time, 2008. The risk factors for measles infection include children with immune deficiency, either due to HIV, human immune deficiency virus, or AIDS, leukemia, corticosteroid therapy, regardless of their immunization status. Travel to areas where measles is endemic or contact with travelers to endemic areas. Malnutrition, underlying immune deficiency, pregnancy, and vitamin A deficiency. The case fatality rate between the years 1987 and 2000, case fatality rate across the United States was 3 measles attributable death per 1,000 cases, or 0.03%. It means less than 1%. In underdeveloped nations with high rate of malnutrition and poor health care, fatality rate have been as high as 28%. In immune-compromised patients, like people with AIDS, the fatality rate is approximately 30%. Clinically, the typical type of measles, the incubation period, approximately 6 to 18 days. 10 days is the most common. Prodromal phase of 3 to 4 days. Fever, catarrh, and inflammation of upper respiratory tract. Complex spot and transient prodromal rash. The eruption stage, the time is 3 to 5 days after fever, but the 4th day is the most common day of eruption. Eruption means when the rash appears on the body, shape is maculopapular, the distribution of this rash behind the ear, along the hairline, face, neck, chest, back, abdomen, limbs, hand and feet, palm and soles. The temperature rises continuously and with toxic symptoms exaggerated. The 4th stage is the convalescent stage, the brown staining, fine briny desquamation, and the course is 10 to 14 days. Sometimes we have what is called atypical measles. It is mild measles, severe measles, toxic and shock type measles, or hemorrhagic measles, or variant measles. These 4 types are atypical, not like the usual ordinal symptoms of measles. The complication, diarrhea, bronchopneumonia, myocarditis, laryngitis, or neurologic complications like encephalitis. The laboratory findings are blood work, serum antibody measures antibody to measles, other antigen and multinucleated giant cells, and separation of the virus from sample of blood. It is diagnosed by epidemiological data, clinical manifestation, and laboratory finding, like multinucleated giant cells are detected in nasopharynx mucosa. Secretion in measles virus can be isolated in tissue culture. Antibody titer and white blood cell is relatively low. Measles should be differentiated from rubella, which is German measles, rosella infantum, and drug rash. It is treated by general therapy, rest and nursing, diet, symptomatic therapy for fever and cough, supportive therapy, and treatment of complication. How can we prevent measles? And this is the most important aspect of our lecture, is prevention to control the source of infection, interruption of transmission, and protection of the susceptible persons. Active immunization and lived attenuated measles vaccine. It's contraindicated in pregnancy. Passive immunization, less than 5 days prevent onset, more than 5 days relieve symptoms. Active immunization, as we will have in lectures of immunization or vaccination, is by lived virus or killed virus particle, while passive by antibodies. In developed countries, most children are immunized against measles. And this vaccine is part of 3 vaccines. We call it MMR, measles, mumps, and rubella. And the vaccine is not given earlier than this, because children younger than 18 months usually retain anti-measles immunoglobulins from the mother during pregnancy. So they keep these antibodies in their blood at the spirit. So we start at a specific age. We can't give it at 18 months. It can be different from country to another. A second dose usually given to children between the age of 4 and 5, and to increase the rate of immunity. The vaccination rate have been high enough to make measles relatively uncommon. And even a single case in a college, dormitory, or similar setting is often met with local vaccination program. In case any of people exposed are not already immune. In developing countries, where measles is highly endemic, the WHO doctors recommend 2 doses of vaccine given at 6 and 9 months of age, and this is what we have in our country. The vaccine should be given whether the child is HIV infected or not. The vaccine is less effective in HIV infected infant, but the risk of adverse reaction is low. Measles vaccination programs are often used to deliver other child health intervention as well, like bed nets to protect against malaria. هذه in countries like in Africa يسوون يعني they perform campaign for vaccination وياها, because malaria is endemic there, so they might give bed nets or anti-parasite medicine, and with it is vitamin A supplement, so to contribute and to the reduction of child death from other causes. In Iraq, measles is one of the most contagious of these diseases and cause mortality, especially in children less than 5. The immunization technique in Iraq since 1985 by using measles vaccine and mixed vaccine in 1988. And then there is a noticeable decrease in the number of cases observed. The Iraqi Ministry of Health implemented a measles catch-up campaign based on WHO recommendation. هذا حتى يعطون supplementary immunization activities to eliminate measles. The age group targeted 19 to 24 years old, And this campaign was unique in Iraq as it was the first national vaccination campaign and included this age group. As you know, these are adults. And the previous campaign targeting the age group 6 months to 12 years. And then after 2003, many changes developed in the society of the country. Healthcare services and preventive measures influenced by the event happened at that time. And the first case after that discovered in Al-Anbar province, 2008. And then spread to Salahuddin, Baghdad, and other provinces. 8,134 cases recorded with 33 deaths in 2009. Then cases increased to about 30,000 with 160 deaths. After the use of vaccination regularly by instruction recommended by Minister of Health in Iraq, the cases started to decrease to 385 2010 and 54 in the first 30 week of 2011. Nowadays it is less, and in 2012 in Iraq there was only one reported case, so we are in elimination phase, but there were a new 8 cases of measles in the Syrian campaign in Nineveh governorate. So measles vaccine is the composition is live virus. Its efficacy 95%, ranging from 90 to 98%. The duration of immunity is lifelong and the schedule by 2 doses. The control is first by preventive measures, which is public education by health department. Private physicians should encourage measles immunization for all susceptible people. Immunization, which is the second part of preventive measures, and control of patient contact and immediate environment, meaning that in case of measles outbreak happened, what do we do? So we report to local health authority. Means that any case suspected to have measles should be reported to local health authority. Isolation, especially children, should be kept out of school for 4 days after the appearance of the rash. And actually, we isolate them more than this period. But as you know, the problem is appearance of rash is not indication of contagious, patient to be contagious. As you know, the infectivity might start before the rash appear. Concurrent disinfection, which is not applicable. Quarantine, usually impractical. Strict segregation of infant if measles occur in institution. It means isolation, separating infant because the highest mortality, the severity of disease more in infant age group. And immunization of contacts. Live virus vaccine should be administered within 72 hours of exposure. And immunoglobulin may be given for immune-compromised person within 72 hours or for maximum protection. And then we have to investigate the contact and source of infection. There is no specific treatment, and during measles infection, vitamin A supplementation to replace body reserve of vitamin A. Okay. The second aspect is we have to start with rubella, which is derived from Latin, meaning little red, discovered 18th century, and thought to be a variant of measles, and first described as distinct clinical entity in German literature. So at the beginning, they thought it is a type of measles. And congenital rubella syndrome, CRS, described by Greg in 1941. Rubella virus first isolated in 1962 by Barkman and Weller. The rubella virus is a virus, RNA virus, and with one antigenic type. It is inactivated by lipid solvent, trypsin, formalin, ultraviolet light, low pH, heat, and amantadine. The pathogenesis is mainly respiratory transmission and replicated in the nasopharynx and regional lymph nodes. Viremia of 5 to 7 days after exposure will spread throughout the body. Transplacental infection of fetus during viremia, which is CRS, as we mentioned. It occurs worldwide, and the reservoir, it is a human disease, and there is no known animal reservoir. Although infant with CRS may shed rubella virus for an extended period, a true carrier state has not been described. The transmission of the virus, it is spread from person to person by droplet shedding from the respiratory secretion of infected person, and there is no evidence of insect transmission. Rubella may be transmitted by person with subclinical or asymptomatic cases. There is a temporized late winter and early spring. The most contagious when the rash first appear, but virus may be shed from 7 days before. With CRS, infant with congenital rubella syndrome shed large quantities of virus from body secretions for up to 1 year and can therefore transmit rubella to persons caring for them who are susceptible to the disease. Clinically, the incubation period is about 14 days. The rate is mild, and up to 50% of infections may be subclinical or inaberrant. In children, rash is usually the first manifestation, and a prodrome is rare. In older children and adults, there is often 1 to 5 days prodrome with a low-grade fever, malaise, lymphadenopathy, and upper respiratory symptoms preceding the rash. The rash of rubella is maculopapular and occurs 14 to 17 days after exposure. Rash usually occurs initially on face and then progress from head to foot, lasts about 3 days and occasionally pruritic يعني itching. And the rash is fainter than measles rash and does not coalesce, unite together. For the rash and lasts several weeks. Post-auricular, posterior, cervical, and suboccipital nodes are commonly involved. Arthralgia and arthritis occur so frequently in adults that they are considered by many to be an integral part of the illness rather than a complication. Other symptoms of rubella include conjunctivitis, nostalgia, or orchitis. Many complications, but they are not common, but they are generally more arthritis, arthralgia pain, arthritis inflammation may occur up to 70% of adult women who contract rubella, but it's rare in children and adult male. Joint symptoms tend to occur about the same time or shortly after the appearance of the rash and may last for up to 1 month. Chronic arthritis is rare. Encephalitis may occur in 1 in 6,000 cases, more in adult, especially female, than in children. And we have hemorrhagic manifestation in about 1 per 3,000 cases. cases occur in children either include orchitis, neuritis, and a rare late syndrome of progressive panencephalitis. We have what is important is congenital rubella syndrome. It is infection with rubella virus, most severe in early gestation. The virus may affect all organs and cause a variety of congenital defects. Infection may lead to fetal death, spontaneous abortion, or preterm delivery. The severity of the effect of rubella virus on the fetus depends at which infection occurs. 85% of infants infected in first trimester of pregnancy will be found to be affected if followed after birth. So it depends on at which time of pregnancy the infection occurred. Defects are rare when infection occurs after 20th week of gestation. We mean congenital defect. The overall risk of defect during the third trimester is probably not greater than associated with uncomplicated pregnancy. So in third trimester, it's very, very rare and minor, the defects. So in CRS, infection may affect all organs. In summary, may lead to fetal death or premature delivery. Severity damage of fetus depends on gestational age. Up to 85% of infants affected, if infected during the first trimester, with deafness, eye defect, cardiac defect, microcephaly, mental retardation, bone alterations, and liver and spleen damage. Regarding rubella laboratory diagnosis, either isolation of the virus from clinical specimen, from nasopharynx, from urine, serologic tests available vary among laboratories. Positive serological tests for rubella IgM antibody, and there is significant rise in rubella immunoglobulin G by any standard serologic assay like enzyme immunoassay. Regarding preventive measures, education of general public on mode of transmission, and stress the need for rubella immunization. Healthcare providers must be aware of the risk caused by rubella in pregnancy. The WHO recommends the use of vaccine in all countries where control or elimination of CRS is considered a public health priority. Two approaches are recommended to prevent the occurrence of immunization of adolescent girl or women in childbearing age through universal immunization of infant, ensuring immunity in women childbearing age for increased impact. Men should be vaccinated. How to control the patient's contact and immediate environment. Reporting to local health authority. In countries where the eradication is a goal, all cases should be reported, even CRS. Isolation in hospital patient with rubella should be managed under contact isolation precaution. Exclude children from school and adults from work 7 days after the onset of rash. Concurrent disinfection is not applicable, quarantine is not applicable, and immunization of contact. Immunization of contact will not necessarily prevent the infection or illness. Passive immunization with immunoglobulin is not indicated. Investigation of contact and source of infection, and there is no specific treatment, only support. The rubella vaccine is a live virus, efficacy 95%, duration of immunity is lifelong and scheduled at least 1 dose, should be administered with measles and mumps as MMR, and varicella. Sometimes we add varicella. It is not available in Iraq, MMRV they call it. Generally we use MMR only. Rubella vaccine indication, all infant 12 months of age and older, susceptible adolescent and adults without documented evidence of robust immunity, and emphasis on non-pregnant women at childbearing age. So this is the end of first part of our lecture today. We'll have a